This is the third installation of the Transnational IR Journal Club. So today it's being hosted by myself. My name is Daniel, and my colleagues Henry and Nico. I like to think of this as the New York episode of the National IR Journal Club. We also have our awesome attending, Dr. Sarkar from Maimonides Medical Center, joining us today, and a bunch of students interested in IR as well. So why don't we go ahead and get started? So today's topic is the SARAH and SIRveNIB trials. We're going to be discussing how those relate to the treatment of hepatocellular carcinoma. So before we get into the trials, I wanted to give a quick background on, hepatocellular carcinoma in terms of, the manifestations of the disease, and a little bit about the epidemiology as well. So it is the 6th most frequently diagnosed cancer worldwide. It's also going to be the 4th leading cause of mortality. And as you could see, it's trending upwards over the years in terms of how many cases we're diagnosing over the last 2 decades. The mortality, unfortunately, is also increasing. So even though we're kind of developing all these novel modalities to treat it, for some reason, people are still dying from it. So that's kind of making this a pretty imperative issue to address in the future. And it has a predominance for affecting males more than females. So here's a comparison of hepatocellular carcinoma in relation to the lung cancer. And we already know that lung cancer is a pretty high morbidity and mortality. So although the death count is not as high, if you look at the y-axis here, we do see that while lung cancer is kind of stagnant in terms of how many deaths it's producing per year, hepatocellular carcinoma is trending upwards. So it's a little bit concerning, and that's kind of why we are picking this topic for the second series in a row. So in terms of risk factors for hepatocellular carcinoma, we touched on this in our last meeting. So I'll briefly go over it again. We have many different things that can lead to hepatocellular carcinoma developing in someone. So there are viral causes, such as the hepatitis virus. There's alcohol abuse, chronic alcohol abuse leading to cirrhosis. There's also these genetic diseases that we see. So things like, hemochromatosis, Wilson's disease, alpha-1 antitrypsin, some of these are pretty rare, but nonetheless, they are, they have been shown to be causes of hepatocellular carcinoma. So this is some of the ways that people can actually develop the disease. And let's talk a little bit about how we actually work it up. So unfortunately, hepatocellular carcinoma is one of those that will come about, is one of those cancers that will come about sometimes, without any symptoms at all, although oftentimes patients will present with weight loss, jaundice, fatigue. That's not always the case. So a lot of times we're finding this as an incidental mass on imaging, but the appropriate kind of diagnostic ladder that we see for working up hepatocellular carcinoma is going to start with an ultrasound of the liver, right upper quadrant area. After confirming a mass, we're usually going to kind of follow that up with a 4-phase CT or MRI. And then we're going to go ahead and take a biopsy of the mass for histological confirmation. Once we confirm that it is in fact hepatocellular carcinoma, because remember, the liver is a really big organ, it drains the entire intestinal tract. So we're often concerned of whether this is a primary liver cancer or whether this is a metastasis. So once we do confirm that it is hepatocellular carcinoma, we're going to go ahead and, kind of classify it in terms of, how bad is this disease? And that's going to be a mixture of both clinical factors as well as clinical factors and like some of the symptoms as well. And the way we do that currently is through the child's Pew score. And however, there's also the Barcelona Clinic liver criteria that's sometimes used as well. And this is going to play a role in not only the, in just understanding the severity of the disease and the symptoms, but also in understanding how we're going to actually treat it, which brings us to the next slide, where we really get a chance to see the kind of both the complexity and marvel of these kind of algorithms that we're going to walk through today. So we see the child's Pew score on the left, basically taking into account the major clinical and lab findings in someone who may have hepatocellular carcinoma. So we're going to take into account the patient's bilirubin, albumin, PT or INR, level of ascites, which is fluid buildup in their abdomen, and then presence or absence of hepatic encephalopathy, which is basically confusion due to elevated ammonia levels. So these factors kind of give us a pretty neat way to classify pretty quickly, rather, how bad the hepatocellular carcinoma is. So class A, B, or C. And then if you go over to the right, this is the Barcelona classification scale. And that really gives us more so something, you know, not only a survival rate, but also gives us a little bit of, it kind of takes into some other factors, right? How many nodules are there, right? How many, is there, portal pressure elevated? What kind of treatment modalities are available? So, ablation, resection, et cetera. So, we really there's different ways to go about this. From what I've heard, and maybe one of the attendings can chime in here, is that for the most part, the Child-Pugh score is the most clinically relevant one that we use today to kind of determine treatment modalities.
Yeah, so Daniel, really nice start to this presentation. I would agree with a lot of the things that you've said so far. A couple of things that I would add. And one of the things that we emphasize in HCC is that it's not like other cancers that are based on pathologic staging, where, for example, a lot of the other cancers use the TNM staging criteria from the AJCC, which is based on pathologic staging after surgery. With regards to staging of HCC, it's done on a clinical staging basis. So Child-Pugh is a way of determining how the patient's actually doing and what their liver function is like. So the Child-Pugh score, along with the MELD score, the model for end-stage liver disease, is a really the way that we determine kind of how the patient actually is in terms of their liver function. And the best clinical staging pathways tend to use some of these elements.
Okay, cool. Thank you, Dr. Sarkar.
That incorporate BCLC, the Barcelona Clinic liver cancer staging. And one of the reasons that it's so popular is that it uses this Child-Pugh score incorporated into it to triage the patients, but also then it also ultimately leads to like a treatment algorithm, which is easy for people to follow. A couple of things that you touched on so far, in addition to some of the things that cause HCC, one thing that we're seeing a much more increasing lately is NASH, or non-alcoholic steatohepatitis. It's not necessarily related to viral hepatitis or alcoholic cirrhosis, but a lot of these patients with a history of fatty liver or longstanding, we're seeing an increased incidence of that, and it's starting to catch up to some of the other. And then you mentioned biopsy. In the past, actually, it hasn't been typical to do a biopsy when we suspect HCC, because most often HCC is actually an imaging diagnosis. However, within imaging criteria, there are times where it can be equivocal, and a biopsy can help differentiate that. But in the very recent era, we have these new medications that didn't exist even 2 and 3 years ago, where the expression on the tumor can help decide some of those, the use of those medications. So we are starting to do some more biopsies.
Okay, cool. Thank you so much. I appreciate that. So there we go. Okay. So I guess the next step is to discuss another algorithm for treating HCC. So here we're going to talk, Here we're going to talk about how we kind of take it, incorporate the child's Pew score and then other criteria in order to figure out whether or not we're going to go with one of the many different modalities that exist to actually treat the cancer, right? So I don't want to step through every single step of this algorithm, but I put this slide here because I wanted to kind of talk about, first of all, the many different options at the bottom that you see for the treatment of hepatocellular carcinoma. That's one thing that I wanted to outline, and that's obviously a big part of why we're here today, is to discuss that. And another thing is just to understand that how many different factors go into working up this disease, right? So child's Pew score, vascular invasion, size of the lesion itself. These are all things that we're going to use to determine where we go in terms of treatment. So let's talk about what are some of those treatment options. So, with many cancers, I think a gut instinct, especially, for those outside of the medical field, might be to like, oh, let's just resect. So unfortunately, resection is not ideal especially for cancers that have multiple lesions or have vascular invasion or have metastasis, because you're not really going to get all of it. So that's not, it's not preferred. So transplanting, taking out the entire liver, just putting in a new one in, sounds great in theory. However, there's definitely not enough livers out there for everyone that needs one. Moreover, what I've seen, at least at the hospital that I'm currently rotating at, is that a lot of patients who have liver disease in general tend to not even be eligible for the transplant list a lot of the time, which is also pretty unfortunate. So transplant is not really, it's not a foolproof method as well. We also have the sorafenib, obviously, which is a pharmaceutical agent, which we'll actually get into in a later slide. So the sorafenib and the Y90, we're going to talk about the mechanisms of action and how those work in a second. But and then we also have TACE, so transarterial chemoembolization. So I do want to touch on that now. So that's where we use these little microbeads. It's very similar to Y90 in some regards. You use these little microbeads and you occlude the blood vessel feeding the cancer. So this is becoming a pretty popular option for kind of middle staged hepatocellular carcinoma. And then you can stack that with the sorafenib, which is, again, a pharmaceutical agent that we'll talk about in a second. And then there's, microwave ablation and ethanol ablation, which I've seen kind of a lot less written on in general. So I'm not going to spend too much time there, but what I wanted to kind of the take home point here is that there are many different options for the treatment of hepatocellular carcinoma. And we're just going to touch on, I guess, two of the really big ones today. So the SARAH trial is a huge trial that was conducted in France. So it was a trial that had over 25 liver centers. All these centers, it was a phase 3 trial. All 25 centers were specialized in the management of liver disease. And essentially, the SARAH trial kind of built upon trials that came before it in order to really understand whether or not there are better alternatives to medical therapy. Because sorafenib worked pretty decently for managing disease, but it produced some serious side effects. And so we wanted to know whether or not the radiotherapy with Y90 is a better alternative, or at least equal to it. So here's our study design and demographics. Essentially, the study included patients who were, not palliative, right? Their life expectancy was beyond 3 months. They were adults. Their child Pew score was A or B, meaning they weren't too severely ill. They also had at least one untreated lesion, and then they had, they had undergone these either 2 unsuccessful TACE treatments, which is that chemoembolization. They were not eligible for other treatments because of whatever reason, or they had locally advanced hepatocellular carcinoma. And on the right, we have a kind of a depiction of what the average patient in the SARAH trial looks like. So, roughly 60, middle 60s, male, overweight, cirrhotic, alcoholic. Over 50% had underwent a previous attempt at TACE for the treatment of their HCC, and a vast majority had unilobular tumors. And here are the exclusion criteria for the trial. So no other primary tumors, no metastases from the primary HCC in the liver, no previous treatment besides TACE, which is an interesting point. No GI bleeds or encephalopathy or refractory ascites. So these are some of the things that they used to really make sure they kind of didn't want patients with any of these conditions. So here we get to the kind of a really important slide where we're talking about what are these two treatments, right? So we have sorafenib, which is our pharmaceutical agent. It's a medication that the patients would take, or we had the Y90, radio embolization. So I want to talk about a little bit about, how these work. So with sorafenib, sorafenib is essentially it's a pill that these patients were given. It's a kinase inhibitor. That's the main mechanism of action. And it's going to inhibit a ton of different kinases. If we have any first or second years, I'm not sure if we do. Oh, we do have a few. So if we have any first or second years who are familiar with, VEGF, VEGF, you guys remember what that might be, what that might control? If anybody remembers the VEGF pathway. So that's going to be an angiogenesis pathway. So sorafenib is going to block that pathway. So that's pretty important, right? Tumors need blood vessels to grow. So that's pretty big. And then the PDGFR pathway as well. I'm not sure. That one's kind of a little bit less popular. I'm not sure if anyone knows about that one, but that one is for endothelial cell motility and apoptosis. So and then we also finally have the RAF pathway, which is a serine threonine kinase. So basically between these three kind of cytokine or molecular target pathways, by blocking those, the sorafenib kind of inhibits the growth of these cancers. Now, Y90 is a super interesting compound. It's basically a radioactive isotope. It's a radioactive isotope that is a beta emitting isotope, and then you inject it very similarly to the chemoembolization. You're going to inject it into the blood vessel that directly feeds the hepatocellular carcinoma. Now, because hepatocellular carcinoma has been shown to derive most of its sort of quote unquote nutrition from the hepatic vein, you basically kind of just selectively target the blood vessels that are feeding this cancer. And the goal of this, and the reason why Y90 is kind of theoretically such an amazing concept, is that you're providing radiation therapy through these like radioactive beads directly to the tumor and nowhere else to the body. So instead of the patient kind of sitting on the table and getting radiation beam blasted all over them, you're kind of delivering it in a super localized and targeted fashion. And it allows for like a lot of selectivity. So that's a pretty neat aspect of it. And those are basically the two treatments here. So at this point, I'm going to give it over to Henry, who's going to take us through the rest of the SARAH trial.
Good evening, everyone. My name is Henry Yelkin. I'm an MS3 from NYITCOM. I just want to thank Daniel Veyg for telling me about this journal club, and I'm very happy to be a part of it. I learned a lot last time, and I learned just as much helping create this presentation this time. So on with the presentation. So this flow chart shows the patient breakdown and how they were split up between the groups, and a few interesting things to note. A number of patients in the SIRT group ended up getting sorafenib instead. And the caption below the figure explains that this is due to developing of worsening ascites, PE, GI bleeds, and any other contraindication to an interventional procedure. And the 16 that did not receive any treatment at all throughout the study were for similar reasons: PE, worsening disease, and deterioration of general status. Out of the patients who received SIRT, half of them received 2 treatments, and 41 received 2 treatments, and those 41 were split up between having bilobular tumors that were way too large for one treatment, tumor progression, and unsuccessful or incomplete treatment. And next slide. So what were the endpoints of the trial? There's a primary endpoint, which is overall survival, and some secondary endpoints. So the primary endpoint is defined as the time from the date of randomization to death from any cause. And then they had to stratify them further as well. And so some of the secondary endpoints. So progression-free survival would be the time from the closest date of radiological examination before the first treatment to when the disease will start to progress. Progression at any site would be from randomization until the first radiological evidence of progression. And progression in the liver as the first event would be time from randomization until the tumor progressed inside the liver. And then there are others such as tumor response, disease control, safety. Those are all, they speak for themselves. Next slide. So this is some of the results from the study. So during the study, 81% of the population passed away, 83% in the SIRT group and 80% in the sorafenib group. And that was also split up into several different kinds of populations. So in the intention to treat group, the median survival rate was 8 months in the SIRT group and 9.9 months in the sorafenib group. The 1 year overall survival, 39.5% of the SIRT group made it past 1 year and 42% of the sorafenib group. When the competing risk was death, the cumulative incidence of progression at any site did not differ significantly between the two. So the chance of the disease progressing, whether you're in one group or the other, stayed the same. When the competing risk was death and progression outside the liver, the cumulative incidence of progression in the liver as a first site was lower in the SIRT group. What does that mean? That just means that with Y90, there's less of a chance of localized disease progression. Next slide. So adverse events. Serious adverse events occurred in 48% of the SIRT population and 52% of the sorafenib population. And the most common adverse event was cirrhosis. Others included reduced general status, tumor progression, and hepatic failure. And then there were adverse events that were directly related to treatments. And 20% of the SIRT group experienced it, while 26% of the sorafenib group did. And then there was also another group called all-cause adverse events. So in the entire study, there were 2,800 adverse events in the sorafenib group and about 1,300 in the SIRT group. So the sorafenib group experienced almost double the adverse events. In the SIRT group, there was a median of 5 treatment-related events, while in the sorafenib group, there was a median of 9. And this makes sense because earlier, we know that sorafenib has like a vast side effect profile, being the systemic drug that it is. So what is the difference between all cause versus just serious? Because a lot of groups, a lot of numbers. So as I mentioned, serious adverse events were cirrhosis, tumor progression, and hepatic failure. The kinds of events that would fall under all cause would be events such as fatigue, diarrhea, elevated LFTs, abdominal pain, raised creatinine, and other more mild side effects. So it could be more like serious and then mild. Next slide. So this is just a chart comparing the most common causes of mortality in each group. So, and what you see from most common to least common is listed. As you can see, it's pretty much the same on each side. If you go to the next slide, some more specifics. So this is specifically the treatment-related mortality. So patients that passed away as a direct cause of the treatment. While the overall deaths followed a similar trend, that slide before, here you can see a difference in the cause of death, most likely due to the systemic effects of sorafenib. So you see the SIRT group is pretty much the same as the previous slide. Sorafenib group, you have myocardial infarction, sepsis, renal failure. One interesting thing is that one patient in the SIRT group passed away from radiation pneumonitis. Next slide, please. So this is something that the discussion talks about. It compares some of the end results of the study. So what both groups are similar in is overall survival, progression-free survival times, which I'm going to expand on, and the terms of expense. So according to the study, they were both equally as expensive. A point to note with progression-free survival time is that most patients already had severe underlying chronic liver disease, which may have previous slide. Daniel, go back a slide. Yeah, so most patients already had severe underlying chronic liver disease, which may have masked treatment efficacy. So the study instead looked at the cumulative incidence of progression at any site and the cumulative incidence of progression just in the liver as the first event. So knowing by that, progression in the liver as a first event, SIRT had a lower incidence, and progression of outside the liver, sorafenib had the advantage. This again highlights that the IR procedure is effective locally, while sorafenib is a systemic treatment. Other than that, the data suggests that the quality of life is better in the SIRT group, better tumor response, better quality of life, and it's a safer procedure than taking a systemic drug. Next slide. So a few strong points of the study. So the few patients who were assigned to one treatment and weren't able to get it were able to be switched and they were able to receive the other treatment. Patients who had extrahepatic, oh, hold on. You went one slide too far, Dan. Yeah, so both advanced and intermediate stage were included. Patients with extrahepatic involvement were excluded in order to compare the systemic treatment with the liver-targeted one. Most patients with locally advanced hepatocellular carcinoma in the SARAH trial had vascular extension.
I think it went black, Daniel, the screen.
Okay.
There we go.
So most of the patients with locally advanced HCC in the SARAH trial had vascular extension, which included complete portal vein obstruction, and that carries a worse prognosis than extrahepatic spread. And there was also a higher proportion of patients who had Child-Pugh score of B than Child-Pugh score of A, which carries a worse prognosis. And patients with previous unsuccessful TACE procedures showed longer survival in the SARAH trial, indicating that they can benefit from interventional procedures. Next slide, please. So some of the strong points. Like I said before, the patients who were unable to tolerate one treatment were able to be switched to the other one. Very few patients did not give consent. Even though SIRT was an interventional procedure, the study claims that patients were interested in 1 to 2 well-tolerated procedures more so than the daily sorafenib treatment, which in an ideal setting would not be discontinued. And experts included hepatologists, so the expertise is necessary due to the difficult to establish associations between tumor progression, disease progression, and treatment toxicity. Because as I mentioned in the earlier slide, in many of these stages, patients already had severe underlying liver disease. Next slide. So some of the study limitations, there were more SIRT than sorafenib patients who were unable to get the assigned treatment. This is possible to the workup that requires days to go through and therefore allows for patient status to deteriorate to a point where the procedure is contraindicated. There's a longer wait time between randomization and treatment. This is important in patients with short life expectancy because it delays treatment. And the lack of SIRT experience. So many centers did not have an expertise level of SIRT administration. And the dose-related efficacy was not evaluated in this treatment. Next slide. Overall conclusions. So if you happen to just zone out for the last 20 slides and need to tell someone what the conclusion was in 2 lines or less, this is your lucky slide. All in all, SIRT offers a higher quality of life and tolerance for adverse effects and may be the better option for less advanced hepatocellular carcinomas. Things to consider in future studies would be cost effectiveness and clinical trials on less advanced hepatocellular carcinomas, because since the mortality was the same, the quality of life was better in the SIRT group. If you could make it cheaper than taking systemic sorafenib, then it would be arguably the better treatment. And now we're going to hand it over to Nico.
All right. Well, thank you to Daniel and Henry Appreciate you guys starting us off. Thanks to Austin for putting this on. Thank you to everyone for coming. So I'm going to try to do about 15 minutes or so, and then we can get into a bit of a discussion. So I'm Nico Sanchez. I'm a fourth year at New York Medical College. I'll be talking about the SIRveNIB trial, which stands for Selective Internal Radiation Therapy versus sorafenib in Asia-Pacific patients with HCC. It was a continuation of the SARAH trial, or maybe a follow-up is the better word, because it just kind of wanted to look at the same thing in a different population. Next slide, please. So we've talked about sorafenib, we talked about Y90. So I'll just go through this quickly. Sorafenib is associated with side effects leading to dose reduction, discontinuation. Y90 has been shown to be effective in previous trials outside of the SARAH trial. And it showed that it had a better quality of life and less side effects for patients, which is why it's useful, because it's also as effective as sorafenib. So the reason that they wanted to do this trial was because the majority of patients with HCC are actually found in the Asian Pacific. But of course, this is a different population than the French population where they did the SARAH trial. And these patients sent out different etiologies of their HCC. So they wanted to see in this group that is a different patient population, different etiologies of HCC, will they have the same responses to Y90 versus sorafenib? So that's why they did this study. Next slide, please. So just to get into the trial itself, they wanted to compare the safety and efficacy of radioembolization, which is the Y90 treatment, but I'm going to call it radioembolization from here on out because I refer to it in all their figures, versus sorafenib. It was a dose of 800 milligrams per deciliter. It was broken up into 2 doses, 400 each dose twice a day. Next slide, please. So in terms of the study design, it was an open label phase 3 trial. It covered 11 countries in the Asian Pacific. It was looking at superiority and detriment, and the primary endpoint is overall survival. So for anyone on the call here, I just wanted to ask, does anybody know what an open label trial is? If anybody wants to chime in the chat or otherwise. Well, that's all right. Open label trial just means it's not blinded. And of course, in this case, it's very easy, or I guess it's very hard to blind a study in which it's sorafenib, which is a medication you take orally, versus the whole radioembolization procedure. So I think that's why they did that. All right, so next slide here. So to touch on the inclusion-exclusion criteria, these were fairly similar to those in the SARAH trial. But just one of the important things here that I wanted to highlight is that the inclusion criteria were patients that did not have extrahepatic disease, and therefore patients who did have extrahepatic metastases were excluded. So they were looking at locally advanced HCC, like the title says. And some of the other exclusion criteria just related to either previous use of sorafenib or previous treatment, previous arterial-directed treatment for HCC. So next slide, thank you. So to talk about some of the endpoints here, the primary endpoint was overall survival, which is from the time of randomization to death from any cause, and that's the proportion of patients that are alive at specified time points. Secondary endpoints, there was some overlap here with the SARAH trial, but I'll just touch on all of these quickly. Tumor response rate is basically based on imaging, and it's an objective measure of the change in size of the tumor. And there's different classifications there. You can have stable disease, you can have a complete response, you can have a partial response. So all those factor into both tumor response rate and disease control rate. Progression-free survival and time to tumor progression we already spoke about. They're fairly similar, but it's basically the time period in which the disease doesn't get worse. So those are fairly self-explanatory. Next slide, please. So here is their randomization chart. So what we see on the left side of the slide is that 182 patients in the radioembolization group, 178 in the sorafenib. But if you go down to the bottom, you see that the treated populations are a little bit smaller. We had 130 in the radioembolization group and 162 in the sorafenib group. So that's 71% of the patients in the radioembolization group who actually received that treatment versus 91% in the sorafenib group. So a little bit of a discrepancy there. Next slide, please. So the efficacy analyses, the overall survival, and all those other tumor response rate, disease control rate, everything else I had listed were done in the intention to treat populations, and the safety analyses were done in the treated populations. So I just want to ask the crowd again, does anybody want to explain what an intention to treat analysis is and why we might use that? If not, maybe we could save it for the end for the discussion.
So intention to treat is analyzing the patients to the group they were originally assigned to.
Yes, exactly. So if you go back one slide just for a second, so you can see the, Daniel, could you go back one slide, please? Previous, I think it jumps around, that's okay. So you'll see on the left side that intention to treat is 182, which matches up with the number at the top, 182. So you analyze the patient groups and their data as they were randomized, versus the treated numbers are just the numbers that were actually received that treatment and completed the arm. So moving on here, we can go into the next slide here. So this is just about the dosing of sorafenib. We have our median treatment duration, 13.8 weeks, and our median dose is listed there. So next slide, please. To jump into our results, so the primary outcome here that they were assessing was overall survival. So that's what I'm going to highlight. I'll talk about some of the other things, but I think this is really the most important thing to look at. So what we found was similar to the SARAH trial, is that there were no significant differences in overall survival between radioembolization and sorafenib. Here's the average 8.8 months for radioembolization and 10 months for sorafenib. We can see that that difference is not significant. Go to the next slide. And in the treated population, we saw similar results. In this case, the overall survival was a little bit longer in the radioembolization group, but it again was not significant. Next slide, please. So they assessed the overall survival at different time points, 6, 12, and 18 months in both the intention to treat and the treated groups. And the reason I wanted to point this out is because there was one time point, which you can see with the yellow arrow, 6 months in the treated group, where there was a significant difference in terms of overall survival between the radioembolization and sorafenib groups, with the radioembolization group having significantly better overall survival at that time point. But that didn't hold true for the rest of the time points. They didn't see that in the intention to treat groups. Next slide, please. So here, the tumor response rate was the other result that was statistically significant. And like I said, that's objective imaging findings that show decrease in the size of the tumor, or potential complete resolution of the tumor itself. So the tumor response rate was significantly better for radioembolization in both the intention to treat and the treated population. Next slide, please. So in terms of the other results, I just put them all here because they were less significant. There were no differences in terms of the disease control rate, and for the progression-free survival and the time to progression, both of those were significantly better in the treated group of the radioembolization. So not the intention to treat, but the treated group, all the patients who actually received those treatments. So in terms of the safety measures that they looked at the adverse events, the frequency of them, and what they were. And they also looked at health-related quality of life, which was done via a questionnaire. Next slide, please. So similar to the SARAH trial, they saw that there were many more adverse events in the sorafenib trial. You can see here 1,031 versus 437, many more serious adverse events as well. As far as the most common adverse events for sorafenib, they tend to be dermatologic and GI. I think Austin put in the chat some of the or a link describing the plantar palmar erythrodysesthesia, which is redness, pain, swelling, cracking, peeling of the skin on the hands and feet, which is a common side effect of sorafenib and some other cancer treatments as well. And the most common for radioembolization were listed there, and they're a little bit more benign than what they saw for sorafenib. Next slide, please. So in terms of the major outcomes for toxicity, because that was the other thing they were looking at, safety and efficacy, They saw significantly less toxicity in the radioembolization group, longer twists, which I'll go through in a second, and significantly better quality of life. So TWIST is an interesting measure, stands for time without symptoms or toxicity. So it's a measure that's taking into account both the efficacy of the treatment as well as the effect on the quality of life. So there can be a treatment that can be very efficacious and can improve overall survival, but if it has a ton of toxicity and leads to a terrible quality of life, it's not really a great balance there. So this measure looks to take both of those into account, to balance them out, and to find a treatment that improves survival and is efficacious, but also doesn't have a very significant toxicity profile. So they saw that the patients in the radioembolization group had a longer time period in which they had no symptoms and no toxicity. So next slide, please. So just to wrap up with some of the major takeaways here from the SIRveNIB trial, there was no significant difference in overall survival between the two groups, radioembolization and sorafenib, which is what we saw in the SARAH trial. But the good thing was that radioembolization was not detrimental, so it wasn't superior, but it wasn't detrimental. Like I showed in a couple slides back, there was a better tumor response rate, and there was a better adverse event profile of radioembolization. So it really just supports the results from the SARAH trial that radioembolization is not worse than sorafenib in terms of efficacy and overall survival, and that it's better tolerated and has a better adverse effect profile. Next slide, please. Just to touch on some quick differences from the SARAH trial. In the SIRveNIB trial, there was a single administration of radioembolization. Like Henry said, there were some patients in the SARAH trial who got multiple radioembolization treatments. They had a bit of a lower cutoff in the SIRveNIB trials for bilirubin. So maybe these patients were a little bit healthier in terms of their liver function in the SIRveNIB trial. And one of the statistical differences that they saw between the two is that there was a significantly better overall survival for patients with BCLC stage C disease in the radioembolization group. So really what this shows is that maybe something that the author suggested that the patients in the SIRveNIB trial were just a touch healthier than those in the SARAH trial. And they thought that maybe that was connected to that lower cutoff for their bilirubin. So just to wrap up with some of the limitations, like I touched on earlier where I showed the randomization scheme, there were a lot of patients in the radioembolization group that did not receive that treatment, almost 30% versus 9% in the sorafenib group. So I think that plays into how you interpret those results. One of the things that was a bit of an issue is that they had 11 different countries that were included in this trial, and not all the sites were equipped for Y90 radioembolization. So this delayed treatment because some of these patients had to travel to these sites in Singapore, I believe. And so some patients withdrew, some patients had their disease progress, and some patients even died, unfortunately. So this plays into the results as well. And one of the things I noticed that Henry mentioned that they didn't mention here was that there was no cost analysis in this study. So I think it's something that could have been useful. So that wraps up my summary of the SIRveNIB trial. But I just wanted to have 2 questions that we're going to finish with. I'll leave this open to everyone to answer. I'll exclude the attendings for now, but if you want to jump in with the explanation, feel free. And I wrote these questions myself, so hopefully they're not way off. So I'll read this out, and if anybody wants to unmute themselves or, oh, we already moved. All right, so why don't we just read it out, and then we'll talk about the explanation. So a 65-year-old male presents to your clinic as a new patient. He hasn't seen a physician in 10 years. He complains of lethargy, abdominal distension, and weight loss. After extensive workup, he's found to have stage 4 hepatocellular carcinoma with extrahepatic metastases. He asked you as the interventional radiologist, what is his best treatment option for his HCC, and what would you recommend based on these 2 options? We did jump forward for a second, but does anybody have an idea of what they would recommend and why?
Yeah, I do. Yeah, I know I saw it, but I would recommend the sorafenib just because it's one, I think the HCC is quite far along, stage 4, but then also the extrahepatic masses, I think sorafenib has more of a systemic effect than the Y90, and Y90 is more for like local destruction of the tumor.
Great. Yeah, that's exactly what I was thinking. Because, like you said, Y90 is a local treatment. All the patients they had in both these studies were locally advanced HCC. So in this patient with extrahepatic metastases, it's fairly widespread. You want to do the sorafenib because it's going to target all those tumors. If either of you or any of the attendings on here want to chime in about what I just said, feel free. Otherwise, we can move on. We have one more question. All right, so let's move on to the second question, and then we can open up the Q&A session. So I'll read this one out. A 72-year-old female presents to your clinic as a new patient. She complains of lethargy, abdominal distension, and weight loss. After extensive workup, she's found to have HCC, which is limited to the liver with invasion of the hepatic vasculature. She asked you, as the interventional radiologist, what her best treatment option is for her HCC. She makes it clear that she wants to minimize her treatment side effects. What would you recommend among the three? Same thing, anybody can chime in here.
It feels like it could be, since the tumor is localized to the liver, although there is invasion of the hepatic vasculature, and she wants to minimize side effects. I am still leaning towards the Y90, and she's 72. She might not be a good candidate for surgery, but that's what I'm going with right now. I hope that's okay.
Yeah.
Okay.
Awesome.
Okay.
Awesome. Yeah, I appreciate it. That's a great answer, and that's basically exactly what I was going for. So I basically put something in there to kind of exclude all the options. So for the sorafenib, she doesn't want to deal with the side effects. So I feel like that was kind of obvious to get that out of the way. In terms of surgical resection, just like you said, she is a fairly poor surgical candidate. I wasn't really thinking about her being 72, but that might play in as well. But the fact that it has invaded her hepatic vasculature means that that's going to be a very difficult, very dangerous surgery. So probably not a surgery that's worth doing or that anyone would really want to do with Y90 as an option. So in this case, I thought Y90 would be the ideal treatment for this patient. So with that, we can open it up for the Q&A. And if anyone has any feedback about these questions, if they're way off, please let me know. Like I said, I just wrote these myself. But thanks everyone for listening. Appreciate it.
I had a quick question. I was wondering about the user variability in that last trial with the 11 different sites, and how big of a deal is user variability when we're trying to look at Y90 or these local ablative therapies.
What was the first part? The word before variability.
Oh, user? The person who's doing the procedure?
That's a really good question. That is not something that they spoke about. And I feel like, when they do a lot of trials, they like to have, a single operator, a certain number of operators. So I feel like that definitely could have played in. I'm not sure how it worked. I might have missed that in the SARAH trial if they all were at the same site. But that definitely could have played in and been, slight variability in terms of the Y90 procedure.
Yeah.
Yeah, definitely. User variability is a big factor in radioembolization. The techniques vary dramatically from center to center, and in the one of the differences that has Y90 has evolved over the last 10 years. Also, in previous eras, the treatment used to just be given in a low bar fashion. So HCC is a very hypervascular mass. So compared to normal liver parenchyma, HCC will tend to be more vascular, and it'll drain the blood supply. So if you were to give, say, Lipiodol, which is what you give with TACE agents, often it'll find its way to the tumor. But with Y90, there's definitely a benefit to giving it as selectively and concentrating the dose. So how selectively people administer the dose makes a big difference, because if you're showering a lot of liver parenchyma with your dose and you're not concentrating the dose very well in the tumor, you're going to get different results. And then that also kind of leads to both of these studies were done with using resin microspheres, or the SIRveNIB products. For general information out there are two commercially available Y90 products. One is the resin microspheres by Certex, the SIRspheres, and the other is the glass microspheres, which are the TheraSpheres. They're made by formerly BTG and now Boston Scientific, and they have different properties. So the resin microspheres they have a lot less activity per seed or per microsphere. So in order to get similar doses, you're administering more particles, whereas in the TheraSpheres, the glass ones, they have almost 50 times more activity per particle, so you're giving less. So on the one hand, the resin microspheres give you the chance for more embolic phenomenon, whereas in TheraSpheres there's almost no embolic phenomenon, and you're really relying a lot more on the blast or the large amount of radiation. And so some of those things make a difference, and that might, it hasn't been, these haven't been studied in a head-to-head versus trial, but some of the studies that have been done at single institutions have had different results and have different techniques as a result. There's one in the chat I mentioned. There's a recent study called the Legacy trial, which has looked at TheraSpheres, and it was a multi-center trial between I think Washington, Northwestern, and Mount Sinai, and they used TheraSpheres, and it included both unilobar small tumors through advanced stage tumors with very high doses up to 400 gray, and demonstrated that there was an overall response rate benefit to using Y90, and that there is basically enough data, or the ability to make the claim that Y90 could be a standalone therapy or used as an adjuvant therapy for treatment of HCC. And then just some final thoughts also. So sorafenib was the very first drug that we had out of anything that showed any kind of a benefit. The SHARP trial in the Asia Pacific about 10, 12 years ago showed that there was some survival benefit to giving sorafenib compared to a placebo drug for advanced HCC. So that's why sorafenib became the wing of the BCLC that was like NYITCOM, where basically you have advanced disease that's not curable, but it's still confined to the liver, and so then extrahepatic disease or worsening liver function to where you couldn't really get some of the therapies. That was the territory of Y90. We're in an exciting time now, though, in the last literally year or two, where we've seen just a tremendous takeoff, and now there's a lot of new drugs, and some drugs that are actually showing a first-line response rate and helping to shrink tumors up front. And now we're studying the effects of Y90 in conjunction with these immunotherapy agents. So it's a pretty exciting time. But again, great job, you guys. This is a really high-level topic, and you guys are doing an awesome job evaluating some very difficult and challenging papers and topics at a level that's far beyond what we see from medical students. So kudos to you guys.
I have a question. So the paper talked about when they were doing like the imaging of the hepatic vessels, they talked about doing protective coiling of the extrahepatic vasculature. I just want to know, what exactly is that?
I'm sorry. Could you repeat? I just like my thing froze for a second.
Yes. So before the actual treatment, they did like an angiogram of the hepatic vasculature, and it talked about protecting the protective coiling of the extrahepatic vasculature. I'm just wondering exactly what that is.
Sure. Yeah, no, that's a great question. So typically and most conventionally, Y90 is done in 2 stages. So I don't know how much you guys have seen this. There are some centers that do this all in one day, like Northwestern does this all in one day, but most of us do Y90 treatments in 2 stages. So the very first time they come, the first step after the consult, and the first time we do what's called a mapping procedure. And this is basically done for a few reasons. One, to get the anatomy, the lay of the land, find out where all the tumors are, figure out the vascularity and where we intend to park the catheter for treatment. And then we inject, which basically amounts to a test particle. We inject technetium-99 MAA. It's the same stuff that they use for VQ scans and all kinds of nuclear medicine studies. We inject that for 2 reasons. One, to determine the lung shunt fraction, so that we can tell that not too much of the seeds are going to the lung, because that could result in too much toxicity to the lungs. But also, we're trying to make sure that none of the flow is going to go into somewhere we don't want it to go. Because if the Y90 particles go into vessels that are going into the bowels, the pancreas, or somewhere we don't intend them to go, or even like parts of the liver that we don't want to treat, that can cause serious problems, especially bowels or pancreas. Patients have actually died from having complications related to that. So for that reason, we will do that mapping procedure. And if there is precarious anatomy, so for example, you're putting your catheter in a vessel that's close to where the gastroduodenal artery comes off, or a gastric artery comes off and will go off to the stomach or the pancreas, then we will test the flow to make sure that that's not going to come into play. But if there's any chance that there's going to be any reflux, or that the flow might go backwards into that, you might want to do what's called a protective embolization. You could put coils into the gastroduodenal artery. And because the stomach, the bowels, pancreas have so much collateral supply from other places, that putting coils won't cause any infarction, then that will protect the flow where you put your catheter, and really reduce any chance that the radiation particles will go somewhere we don't want them to go. So I would say most of the time in the early days when people were first doing Y90, it was very common for people to coil out a lot of these vessels. Now with mapping and also doing very selective distribution and treatments, it's very rare that we need to, but we always do the mapping procedure, and just in case. And there are occasions where, to be safe, we'll coil out one of the vessels to make sure that we're going to be very safe when we give the treatment.
Thank you. That was very informative. Thank you very much.
I had a question as well, if that's all right. So in the SIRveNIB trial, I know it was mentioned in the presentation as well that in the BCLC group, the overall survival is actually greater with the radioembolization. But they also did stipulate that in that group that the sample size was actually quite small, and that was one of the limitations of that trial. So I mean, if is it possible to predict whether or not, or to foresee if there was another trial that increased the sample size? Do you think there still would be such a significant difference, or would it be more close to what the other groups were in terms of there being a very similar overall survival?
So I can jump in and say that in terms of that, the one thing that they mentioned in the paper was that they had a significantly better overall survival in that group. And I guess the other one that you can compare it to is the SARAH trial. But in the SIRveNIB trial, or SIRveNIB, I'm not sure how you pronounce it honestly, they had a lower cutoff for the bilirubin. So they thought that maybe those patients with stage C disease were slightly healthier in terms of their hepatic function as compared to those in the SARAH trial, which had a higher bilirubin cutoff of 50. But, it would be interesting to look at, how far along the BCLC staging can you go to treat a patient with Y90 and still have benefit. I think that would be something interesting to look at. Not sure if anyone else has a take on that as well.
Great, thanks.
And I see that we got a ton of great discussion going on in the chat as well. I think that's one of the most useful parts of this meeting is that we get some great minds who are, have years of experience in the field, Dr. Vatican-Cherry and Dr. Sarkar, and they're able to kind of answer our questions and kind of give us like insight onto like the real life application of these trials. And because things may not always be, it's kind of like the same way things you read in the textbook may not always be the same in real life. Same thing with the trials, right? So we appreciate you guys answering our questions and giving us all of your insight. Honestly, it's great. Thank you. So does anybody have any other questions for the presenters or for the attendings that we have with us today? I do know it's Thanksgiving Eve, so everyone's probably home with their families or are anticipating to be so. So I don't want to take too much of people's time, but at the same time, if we do have any questions, we should have them answered.
I guess I just have a quick question. I apologize if I'm keeping people from going to sleep, but just with regards to the SIRveNIB trial, I was looking at figure 3 again, and I guess I just want to get a better sense of why exactly you can get this big gulf between DCR and TRR as secondary outcomes, just because it's very surprising to me that you would have such a strong difference in the intent to treat population for the TRR group leaning towards radioembolization versus the DCR outcome, where they're basically the same. In fact, it looks like intention to treat outcomes for sorafenib are even slightly better by just a smidge. And is that just purely a reflection that perhaps sorafenib is just a better disease stabilizer versus radioembolization? Because I believe the only difference in those two outcomes is stable disease inclusion.
Can you pull up that slide?
Yeah, so you were at, can you just, it was a little hard to hear you, but could you just like put like the bottom line of your question in the chat?
Sure, I apologize.
I think I got it, but
yeah, I apologize. I hope I'm clearer now. But the basic summary is that there's a 3B to this figure as well, and which shows the DCR, which is also a secondary outcome that is very similar to tumor response rate as I understand it. But I think, and someone could correct me if I'm wrong on this, the only difference is the inclusion of stable disease as an outcome on imaging. But it's very surprising to me that when we look at DCR versus TRR, we get to such a stark difference for the two modalities.
And that's what the SHARP trial showed, right? It didn't show a lot of overall response rates. It's really the anti-proliferative effect, but it clearly had an improved overall survival. So, these surrogates are all interesting in the time to progression, PFS, but it doesn't tell you is the patient going to fundamentally live longer. And so really when it comes down to it, the patients in your office, they want to know, how long do I have to live and can I live longer? And am I going to be miserable? Okay, so they want quality of life and quantity of life. So those are two things that I have to kind of weigh in when I'm making a decision, knowing that I have inherent biases because I'm an interventionalist that, hammer nail, that I think my therapy is going to be well tolerated. But these clinical trials, especially when adjudicated by an independent observer, take out some of the human biases that we as interventionalists or medical oncologists or hepatologists may have. So in general, in theory, time to progression, PFS, should correspond to survival, but it doesn't necessarily, as shown by the OS trials.
This is similar to the data that we saw in other disease states using Y90. Also, the Y90 trials for colorectal cancer. Also, they had much better time to progression and progression-free survival in the liver, but not necessarily demonstrating overall survival. And so often you have to balance that with your patients as far as like whether the quality of life is potentially going to be enhanced by doing the treatment, and whether the patient's liver function is at a state where treating the tumor even makes sense. I will often see patients in clinic where it really becomes a question. Just because we can do Y90 doesn't necessarily mean that we always should on each patient. You have to really take into account their liver function and overall picture. And again, sorafenib and these systemic treatments are systemic, so they're potentially quote unquote stabilizing disease throughout the entire body, but our treatment effects are very localized to where we're getting responses very specific to tumors that we're targeting. But some of that is also evolving as we're seeing the combination of Y90 use with immunotherapies, and now we're potentially seeing benefits to where the immunotherapies may work better, or they may target tumors that weren't even treated specifically with a local regional therapy. So it's a very evolving space.
Yeah, and I think that's an important concept. So if you, again, kind of brought in the chat, how bad is a tumor? How bad is liver? How bad is a patient? So if the patient's frail, they have an EF of 20%, their ECOG is 3 or 4, it's, probably better to leave them alone, and they have a 2-centimeter tumor, all right? So you always have to weigh that in, and the natural history, some of these processes are uncertain. So you follow them, right? You don't necessarily give up. If maybe their functional status may improve, maybe some of these things, they can prehab, improve their frailty, et cetera. You give them a shot, but at the same time, you always have to think supportive therapy, hospice, palliative care are all things you should be thinking of for this patient population, whether they have end-stage tumor or end-stage liver. So any of these patients that you're seeing, you offer them all those options, and just all your role is in the clinic as a guidance counselor. Your knowledge of disease, the epidemiology, natural history, not only of this disease, but their other comorbid conditions, the patient's desires, right? Their wants and desires. That's what clinic's about. Figure that out, and then you support them through it. And you don't say one and done. Hey, I have nothing to do. See you later. You're like, hey, I've seen you. I manage this condition. Let me follow you and make sure I get you the support you need so that you can feel comfortable through this journey. So you're on a journey with this patient throughout their life, and you're on a journey with the family throughout their life. And even if you can't offer an intervention, doesn't mean you as an, if you're an interventional oncologist or vascular interventional specialist, you are going to continue that ride with them and without abandoning them. So that's an important concept. And that's why this level 1 evidence as a scientist is so critical, right? So we need to be able to go, hey, maybe this trial doesn't improve overall survival. Maybe we need a better selection, because if you look at these trials, one of the conditions that you have to think about, what if you could have randomized them, got them to therapy as early as you could get them to sorafenib. So if you look at the SARAH trial, it was within 7 days. You look at the Y90 trial, by the time they get to therapy, it's almost 30 days in pretty advanced population. So is that the problem? Was it that we were too late? So maybe your study design should be different, that you target these patients earlier. So again, just because it's arguably a negative trial didn't meet overall survival endpoint, maybe if we design it differently, if you really believe in it, then we should look at it fundamentally differently, you know? And this can be showcased in, if you look at the intracranial stroke therapy, if you look at the original trials, they were negative, right? PROACT, NINS, et cetera, when you look at intraarterial thrombectomy, even the MERCY trial. But then in 2015, 5 randomized trials looking at Centriva, which is a new device, showed a dramatic improvement in modified Rankin scale at 3 months with the number needed to treat of 2 to 3, which is unheard of in medicine. And that was just because of change in study design and selection and the technique. So, always be thinking that, hey, maybe this trial is negative, but we need to do better. And always look at the quality of the evidence. These are prospectively gathered data, intention treat analysis properly done. But if you don't have core lab adjudication, if you don't have, if you have a high crossover, the study design may be not validated. So always look at that as a scientist. That's what you need, because when you're counseling a patient, you need the best level of evidence to support your decision, so you can give them an option. And so I think, and all options are important. Just because we have a hammer with Y90 or TACE or ablation doesn't mean that the systemic therapies are not the right answer in many of these patients. And we should certainly guide them and counsel them, and even guide our med-oncs on what we think is best based on evidence.
Absolutely. One last thing I'd add is that when treating HCC, the standard of care is for all of these patients to be presented in a multidisciplinary committee or a tumor board, and for that institution to have some sort of affiliation or ability to refer to a transplant center, because each of these patients, transplant and the hepatology and the workup and the management of the liver disease is as important as anything. And so, for example, in my institution, we're not a transplant center, but we see a lot of HCC. Every single HCC patient is presented in a tumor board, and all of the patients that are eligible are seen by hepatology and referred for possible transplant evaluation. And that's just something that this is a disease process where you do have a lot of responsibilities as a clinician. We're sort of like almost like a primary care physician for the HCC disease. But you can't treat the disease in an island either. This is something where we have to work very closely with medical oncologists, GI, hepatologists, surgeons, and basically everyone.
Yeah, and I think it is important to understand the trial data. So look at the transplant data, the Mazzaferro data from Milan, the Yao data from UCSF, extended criteria. Look at the ramifications and survival rates of those population. Look at the resection data. Look at the resection versus ablative therapy data, right? And I think we talked about it at our last transnational conference, right? There's a couple of randomized trials looking at that in the HCC population. Look at that. And then look at the local regional therapy, Low et al., Lovett et al. Data for randomized trials looking at TACE versus supportive therapy, right? Mm-hmm. And now let's look and see, do we have TACE versus Y90? We really only have a single center phase 2 trial prospectively gathered in the Premier. And now we're looking at systemic therapies, which have now, like you said, Dr. Debkumar had suggested, that now the gold standard has changed, right? So gold standard is now sorafenib. If I were to design this clinical trial now, I would argue that I need to now compare it to atezolizumab, because if you look at BRAVE, your overall survival, the median overall survival for of atezolizumab is arguably going to be is longer than sorafenib. So now we're changing the landscape. So if we were to repeat this trial, would we still have the same OS? You have to question that. Now, again, even though we may be in the Y90 or TACE, we're ultimately in the patient business, right? Taking care of people. Ultimately, we want to reduce these events, right? Our goal as a society worldwide is a reduced NAFLD NASH, so we don't see this. So if you can eradicate this and I don't see another HCC in my clinic, I'm okay with that. All right, and I want that. And so that's what you should all be striving for. As young physicians, your goal is to educate patients young and old. Hey, we got to control metabolic syndrome. We got to adjust for this. We got to tweak this so we can avoid this. We can't say, hey, throw pills at this. We got to change our landscape by doing that. So these are all your roles and responsibilities. You got to know everything that's known by the other doctors in that multi-sys, and you got to be the counselor of that patient. Sure, you're going to refer to a transplant surgeon. You can't do a transplant. You can't do resection. Maybe you're not going to be offering the systemic therapies, but you should certainly know about all that because the patient ultimately expects you as their doctor to know that. And that's what I've seen over the course of time seeing patients. And you as an interventional physician will know a lot about a lot of diseases, right? So they have an aneurysm, you can manage that. You have this thing, you can take care of that. They have back pain, you can sort that out. So there's a lot you can offer the patient. And because you're a physician who has that knowledge, you can't hide it from them. You have to take care of those other issues as well when they come to your clinic.
All right. Thank you for that, Dr. Vatican-Cherry and Dr. Sarkar. I think we're gonna wrap up for today with that, on that note, on the very, broadly applicable note. So we do appreciate those words. And we do thank everyone else for coming. Thank you, Austin, for creating this concept and for allowing us to present today. Thank you, Nico and Henry, for collaborating with me on today's project. It was great. And thank you to, again, Dr. Sarkar and Dr. Vatican-Cherry for taking some time out of your schedule to chat with us, give us some feedback, and give us some awesome words from your experiences. So I think Austin will be in touch with everyone regarding the next segment. I'm not sure which schools or which medical schools will be collaborating, but that'll, I guess, come out in the next email and on the Twitter page as well. Yeah, so happy Thanksgiving in advance to everyone. Have a great night. Thank you for tuning in.